thank you all for turning up, and thank you for having me as well. Um, I'm aware that many of you have different experience and experiences in hypertrophic cardiomyopathy, and I wanted just to speak a little bit about symptoms and lifestyle and therapies, but I think it's difficult to do that without really sort of having a bit of a background about HCM and why people get symptoms and the various ways to alleviate them. So I wanted just to talk a little bit about the background, and then we can discuss more about what symptoms are and why they might occur. So hypertrophic cardiomyopathy, or hypertrophic, just means a thickening or too much of. Cardiomyo pertains to muscle of the heart, so myo being heart and pathy just being abnormal thereof. And you can see here this heart on the left ventricle, the main pumping chamber of the heart, which pumps to the body via the aorta, which is this big blood vessel here. You can see there's a nice open conduit between the left ventricle through the aortic valve into the aorta. But this heart on the right with hypertrophic cardiomyopathy, you can see there's a thickening here, predominantly of the septum, which is the wall in between the two main pumping chambers of the heart. That's become quite thickened, and to a lesser extent, this other wall here of the heart. And that has a number of different effects on the heart function. So first of all, you can see the chamber on the left is much bigger than that of the right. So particularly at rest, people find that they tend to be okay, but when they exert themselves, walking up hills, walking upstairs, actually that small pumping chamber means that the heart is less able to increase the amount of blood which comes out. So that can cause people to be breathless or have chest pain or feel tired on exertion. And the second aspect here is where this septum sits. You can see that enlargement is just starting to encroach, or quite significantly here, encroach on this outflow tract of where the blood would normally nicely flow out of the heart. So you can imagine that if the heart is trying to contract and squeeze blood into the aorta, there's a physical obstruction here, which, as we'll discuss, doesn't occur in everybody, but if it does, can cause symptoms as well. So I think it's important to acknowledge that there are a wide number of forms of hypertrophic cardiomyopathy. There are some people who live into their old age never knowing that they've actually had the condition at all. Other people present with relatively severe forms very young, and actually the pattern of distribution of where the thickening is can vary person to person. So if we just look at this kind of third one in here, you can see that the predominant area of where the heart is thickened is towards the apex, or the tip of the heart. And you can imagine that when that heart is contracting, actually the impedance on the blood flow is much less than somebody here who might have this heart. You can see how the septum is that much thickened and encroaching here on the outflow tract. So there is a wide range of how HCM can affect people's hearts differently. And because of that, either because of the change in the size of the heart cavity, or whether it does or doesn't obstruct the blood flow out of the heart, that can impact on people's symptoms day to day. And as I say, it's important to recognize that you can have thickening to a greater or lesser extent, which may or may not cause obstruction to the blood flow as it comes out of the heart. So I wanted just to put a couple of videos in, just to kind of show what this really means in practical terms. So the heart on the left is a normal heart, actually, of a good friend of mine. You can see how the walls of the heart are very thin and contracting nicely, and there's a nice big cavity for the blood to pool into before it's ejected here out of the aorta. So this is just a cross section of the left ventricle here, and you can see that the blood's flowing nicely into the aorta here. And if you contrast that to the heart on the right that has hypertrophic cardiomyopathy, you can see that the pumping chamber of the heart is much smaller. And if you look specifically up here on the septum, which is the bit we were talking about before, you can see how that's now starting to encroach on the blood flow out of the aorta. And you can see these streaky lines here, and that's just turbulent or high pressure flow as the heart is struggling to eject the blood out. And you can actually see here that the mitral valve here, this starts to get sucked into this outflow tract, which narrows it further. So it's a lot of people's symptoms, if they have obstructions, to do with the narrowing of the outflow tract and impedance of the blood flow as it comes out of the heart. And this is about the best analogy I can think of, and I'm very open to any other suggestions really. But if you imagine you're drinking out of a cheap drinking straw and you suck on that straw as hard as you can, the straw collapses. And that's due to a high pressure difference in that straw. So you have a very negative pressure in your mouth and a very high pressure here. And we can recreate that system in the heart. So the narrowing is not fixed. The narrowing will often be dynamic. And if you have a very high pressure in the heart, that can cause the outflow tract to contract in, which is why we give medicines to relax the contraction of the heart, such as bisoprolol and verapamil. And there's also a number of different situations which we'll talk about, such as dehydration, having big meals, or giving drugs which can relax some of the blood vessels in the body, which can cause that pressure gradient to go the other way, where the pressure is very low in the body, and that can also cause a narrowing of the tracts out of the heart. So what symptoms do people get? Well, there's a huge variety. And as I say, there are some people who go through the entirety of their life not knowing that they've actually got HCM at all. And it's only when they have investigations for maybe an operation or investigations for other symptoms that this is found as what we term an incidental diagnosis. And at the very much other end of the spectrum, there are people who have very much more progressive, severe forms, which present much younger, and people have much more limiting symptoms. And it tends to be that patients with the outflow tract obstruction tend to have more severe symptoms. So some patients will get chest pain, and that's for a number of reasons. So just the quantity of oxygen, or the quantity of muscle that people have in their heart demands a high amount of oxygen. And if not enough oxygen is supplied to that muscle, that will cause the muscle to produce lactic acid, and that will generate chest pain. It's important that this is distinct from coronary artery disease. So the plumbing or the blood supply to the heart is often normal in people with HCM, but obviously that can coexist. And I just wanted to flag really that any rest pain for more than about 15 minutes does need investigation, as it would do for anybody else. So people get breathless for a number of different reasons. So as the heart becomes thickened and the cavity size gets smaller, the heart pumps out less blood with each contraction, and that means that the heart is less able to meet the demands of the body. And this is often fine at rest. People are quite comfortable, but as soon as you try to exert yourself and the demands of the body and the muscle goes up, the heart is less able to meet this, and that can cause people to be breathless. The thickening of the heart, whilst the contraction of the heart is essentially normal or often hyperactive, the stiffness of the heart muscle means that when the heart relaxes and fills, it fills more slowly than a normal heart muscle. So when the heart is beating quickly, actually the heart doesn't fill properly, and this can cause a drop in the blood flow out of the heart. And as we've said, if there's natural obstruction to the blood flow out of the heart, this can impede the blood flow and make people breathless because of that. So palpitations. It's a very common symptom that people have, and can cause quite a lot of anxiety. And palpitations are quite simply an awareness of the heartbeat. And there can be very benign forms of these. So every heart, every normal heart, every abnormal heart will have a number of single extra beats, and we call these ectopics. And people tend to describe these as a feeling like a bit of a sinking feeling and then a big thump as they have an extra beat. And a lot of the time, these, unless they're very common, these tend to be benign. And other times people tend to have an awareness of their heartbeat, which is normal, can be at times of stress or anxiety, or often lying in bed. And the reason that we do tend to monitor people's hearts, when a lot of you may have worn a Holter monitor for 24 hours or longer, is that sometimes these palpitations or HCM can cause rhythm problems of the heart. And these tend to be either atrial fibrillation, which is an abnormal rhythm coming from the top of the heart, or rhythms that come from the thickened heart muscle, which are ventricular rhythms. And these are things which we screen for. And I think in terms of things for people to look out for, it's often difficult to distinguish from people's symptoms alone, but there are some things which I tell my patients to look out for. And these are palpitations where people will say, I was sat there having dinner and it was like a light switch and somebody turned my heart on and it went boom, 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 and then turned it off again. And that can be more indicative of this being a rhythm problem rather than just a normal awareness of the heartbeat. And certainly if people have palpitations that are either very fast or associated with dizziness or blackouts, that's something which we would want to know about. And certainly if that's something, if you're having dizziness and blackouts on an evening, that's something you should seek medical attention for early. Also, if people are having more sustained runs of palpitations, so if these are lasting sort of minutes at a time, or if they're unprovoked, or if they're becoming more frequent, that again is something that we would like to know about. So people can have dizziness with HCM, and particularly with outflow tract obstruction. So particularly when people find if they stand up quickly, if they've had a big meal, or if they're on exertion. And this is simply the fact that when you're standing up, anybody's body takes a while to adjust to blood pressure. So when you stand up, I compare it to like a hose pipe with a level of water. If you lift that hose pipe up, in order to get that level of water back up to your brain, it requires the blood vessels to squeeze and the heart to beat more strongly. But if there's an outflow tract obstruction, the heart isn't able to adapt to that as easily. If you eat a big meal, the blood is diverted to the gut, and the heart has to compensate, which again can struggle to do if there's obstruction there. And also on exertion, the demand of the body goes up, and again, the heart isn't able to compensate as easy. Sometimes rhythm problems can cause dizziness, but that's unusual, as we've talked about before. But as I've said, if your dizziness is progressive or associated with blackouts, this is something that we'd like to know about. So I wanted to talk a little bit just about why we give the different medical therapies and how they can be related to people's symptoms, because I think it can be quite helpful sometimes to, first of all, know where these symptoms are coming from, but also why we give the tablets we do to try and help those. So many of you may be on beta blockers such as bisoprolol or metoprolol or carvedilol, any of the ols, or a calcium channel blocker such as verapamil commonly, sometimes diltiazem, and also tablets called disopyramide. And these, what might be seen as conversely, actually reduce the heart rate and contractility. Now, in HCM, the heart is beating often too quickly and too vigorously. And by slowing this down and reducing the contractility in the heart, we can increase the filling time of the heart so it relaxes nicely and fills with blood. And so that when it contracts nice and evenly and doesn't generate the high gradients, which we've talked about with outflow tract obstruction. So they overall just tend to relax the contractility of the heart and can make it more efficient with HCM. So there's a number of different drugs which we tend to give to reduce rhythm problems, which can be associated with palpitations and breathlessness. I won't go into these in any sort of detail because there's a wide range of these for different types of rhythm problems. But broadly, the aim is to try and suppress these extra heartbeats or ectopics if they're very, very frequent, and to reduce the risk of any sustained rhythm issues. Now, again, one of the reasons that we do heart monitors sort of yearly, 18 months in many people, is that we're looking out for any abnormal rhythms that they may not be aware of. So atrial fibrillation is a rhythm problem at the top of the heart, where rather than contracting nice and evenly, it wriggles around like a bag of worms, which doesn't always have a huge effect on people's symptoms, but can cause blood clots to form within that chamber. And we always have something we want to know about. We have a low threshold for giving people blood thinners in that situation. And if we deem people to be at very high risk of having dangerous heart rhythms, then something which we can talk about with people is implanting a cardioverter defibrillator or an ICD, if we deem people's risk of having dangerous rhythms high enough to protect them from this. So some of the drugs we give can improve the blood supply to the heart muscle. So as we've talked about, chest pain can be associated with a supply and demand mismatch in the heart muscle, where you've got lots of heart muscle, and the vessels within the heart muscle struggle to supply that. And that can sometimes be due to dysfunction in these blood vessels. So the drugs we give for chest pain often try and reduce the heart rate and how much the heart contracts, as we've talked about. But there's also drugs such as ranolazine or sometimes ivabradine, which we will give to dilate the small vessels in the muscle and improve the blood supply as well. So I want to talk briefly just about some lifestyle adaptations and why they might be helpful in some people's symptoms. So we've talked about large meals. So when people have large meals, first of all, a lot of the blood vessels dilate in the body, so the volume of blood is much greater, and that can drop the blood pressure in the body, and it can divert the blood away from the heart. And overall, if there's outflow tract obstruction, this can increase the gradient, which we talked about is something we want to avoid. So having smaller, more regular meals, particularly if you're finding that meals will potentiate or exacerbate your symptoms, then that can be quite helpful. So as we've talked about, there are changes in the cavity size of the heart, and particularly with obstruction. Changing posture quickly can exacerbate people's symptoms, and generally this is dizziness, but sometimes also chest pain and palpitations. One thing that will be a theme through this is the importance of staying hydrated, which I can't overstate enough. and to take it slowly when you're going from lying to sitting or sitting to standing, particularly if this is something that you're aware that your posture will induce these sort of symptoms. We get asked a lot about exercise, and it's often a very specific case, person to person, because generally we encourage certainly light exercise. In most people, moderate exercise such as jogging or rowing is absolutely fine. In some people, because of the potential risks of exercise, we are more conservative in what we advise. But there are some general advice that we can give. So this is generally warming up slowly. The mainstay of the advice around exercise tends to be avoiding things that will lead to big surges in adrenaline or big surges in heart rate that can cause the heart either to go into abnormal rhythms or sometimes make people feel very unwell if the heart isn't able to adapt to the exercise that it's faced with. So warming up slowly, avoiding sudden bursts of exercise or high intensity training. Certainly have more sessions that are shorter. And again, hydration is absolutely key, and replacing electrolytes, particularly in the hot weather. And as a general rule, if you're able to do exercise and complete sentences, that's probably absolutely fine. And certainly if you're having dizziness or blackouts on exercise, you're pushing yourself a bit too much from what your heart's able to deal with. But as I say, they're very specific recommendations person to person on the whole, and it's something that you should bring up in clinic and have a chat to the person that's treating you. And more broadly, not strictly exercise, but avoid hot tubs and saunas. These can dilate all the blood vessels in the body and drop blood pressure very quickly, and can be dangerous for people, particularly if they have obstruction. So dietary advice, we broadly say to avoid excess caffeine and alcohol from two angles, really. The first is that alcohol in particular can cause people to become dehydrated, and any drop in the blood volume will increase any gradient coming out of the heart because that outflow tract will become narrower. But also any stimulants, so excess caffeine, excess alcohol, can potentially provoke rhythm disturbances. Again, we say hydration is key, so around 2 litres of water is ideal. We get asked a lot about diet, and there's not a direct link necessarily between people's diet and how the heart muscle disease progresses, but we'd always recommend general healthy eating advice such as Mediterranean diets, and this is to help reduce the risk of coronary artery disease and diabetes. High blood pressure, which we'll talk about, is an important modifier in hypertrophic cardiomyopathy. So we'll talk a little bit about some of the medical treatments. I think broadly, if your symptoms are progressive or you're very limited by them, then again, we'd like to know about it, because we do have lots of options in HCM. Often this will be in discussion with yourselves about how much of a problem your symptoms are, how happy you are taking tablets, how well you're tolerating various medications you're on. But there may be options to increase these or add further medications, or perhaps offering procedures to reduce obstruction if this is present might be the right way forward. And just in terms of blood pressure, so the heart is like any other muscle in the body where if it's working hard, if it goes to the gym, it will get thicker. So if you have a heart that's pumping against high blood pressure, then that's like your heart being at the gym, and that will induce thickening in anybody's heart muscle. And particularly if you have a preponderance to thickening because of a genetic cardiomyopathy such as hypertrophic cardiomyopathy, then any changes in blood pressure, particularly high blood pressure, that will have more of an effect on the thickening of your heart muscle than we'd expect it to in the general population. So it's really important to try and minimize the progression of disease, that blood pressure is kept well under control. I wanted to touch briefly, and we've had a couple of questions about these, and I'm sure we'll talk much more about these in a few moments. But there are a number of medications which are approved in the US a couple of years ago, and were approved in the UK late towards the end of last year. And these are medications called myosin inhibitors. And myosin is a component of heart muscle, and by inhibiting this, it actually reduces the contractility of the heart muscle fibers called the sarcomeres. And this has effects in a number of ways. So it reduces the pressure gradient within the heart, certainly within animal models during trials, but also we've started to see in humans, as we've started using this in people as well, that actually the hypertrophy can reduce over time. And in the absence, even in the absence of obstruction, this can cause less stiffness in the heart muscle, to cause the heart to relax more easily and have more, be physiologically more efficient. But also, if there is obstruction there, obviously that would be expected to reduce, and that's been shown to have very significant results in patients in early trials. It's a relatively new treatment. The trials, which were initially started, I think about 4 years ago, are still ongoing. And originally they were to look at the safety of the medication in the short term. Then they were to look at the potential benefits of the medication in people with HCM. But they've now moved into the phase where the trials are specifically looking at long-term safety and benefits of these drugs. So the suggestion is that there is long-term good safety data in these, but the trials are very much ongoing. It's important to note that the medication that's licensed in the UK is mavacamten. It's currently only licensed for obstructive hypertrophic cardiomyopathy. There are trials which we can talk a bit about, which are also looking at whether there'd be a benefit in non-obstructive disease. There are a small number of centres which are currently prescribing this, and this is largely due to logistics of giving the medication. So there's a number of tests, specialist tests, which have to be done to make sure that the drug will be metabolized safely when it's taken. And as a drug which specifically tries to reduce the contractility of the heart muscle, there's obviously a potential risk of harm because of that. So when people are taking this medication, they'll need regular echoes to make sure that the heart muscle isn't reducing beyond a safe limit. But aside from these logistics, it's something which all of us in the service are very much optimistic about in terms of their benefit, and I would hope that provision would increase in the coming months and years, certainly in the larger cardiology centres. So, in summary, there are many forms and degrees of severity of hypertrophic cardiomyopathy, and people's symptoms can vary much from person to person, but these tend to be related to changes in the blood flow within the heart or out of the heart, related to rhythm abnormalities or insufficient blood supply to the heart muscle. And these are the things which we try and treat through lifestyle modifications or medication. Lifestyle adaptations can help. Hydration is key. And I'd hope the availability of treatment will increase in the coming months to years. So thank you all very much for listening. And we've got a couple of questions that were sent in previously, so I'll probably go through first. But Jayne, is there shall I go on to them?
Yeah, if you want to go on to those, I've got 8 questions so far. So if you want to start with the 2 that were sent to you anonymised. Okay,
super. Yep. So first question was, how is mavacamten tolerated, and are there any long-term concerns, and when, if at what stage should mavacamten be started, and earlier the better? So it seems to be very well tolerated in the vast majority of people. The main long-term concerns are around the fact that this can potentially make the heart muscle weaker. Now, in people with hypertrophic cardiomyopathy, that is a good thing, but only to a point. And there may be a cohort of people which are unable to tolerate mavacamten or similar drugs because it weakens the heart muscle beyond a point of safety. So that's still something which we're looking at in terms of safety. But the long-term data does seem to be good. There are ongoing trials, and it generally seems to be very well tolerated by most people. Now, at what stage should mavacamten be started? Earlier the better. Well, this again is something which is still very much under review. There has been good, clear, and impressive data to show that in people who have obstruction currently, it can induce regression of that obstruction, and people do very, very well from that. There are trials at the moment which are looking at whether there's a benefit in non-obstructive disease. But I think with all of these will be based around people's symptoms in the first instance. So I think what will happen with the trials is that we'll establish that there is benefit in obstructive disease. We may or may not then show that there's a benefit in non-obstructive disease. And then the question really will be around if and when, around what time we prescribe this to people, whether we wait for people to have symptoms or whether the trials actually show that there is a benefit in treating people's heart muscle disease before they develop symptoms, because that ultimately may make them live longer. And these are all questions which we don't know at the moment, but there are certainly many active trials which are looking into these. So the next question we had was, are there specific medications to help with the relaxation of the heart in HCM, and which types of medication are best for this? So thickening of the heart muscle causes it to relax poorly. We don't have specific medications to improve heart relaxation. So, but what we can do is improve the function of the heart by proxy, essentially by slowing down the heart rate and reducing how vigorously the heart contracts. And this is why we give medications like beta blockers or verapamil. And the hope is that with the myosin inhibitors, such as mavacamten or aficamten, by reducing the thickness of the heart muscle, then actually this will improve the relaxation of the heart as well. As I say, particularly, this is relevant in people who don't necessarily have obstructive disease. And that kind of answers the second question as well. So could it be prescribed in the future to help specifically with the relaxation of the heart if further research studies indicate benefit in people diagnosed in HCM without obstruction? And absolutely yes, but I think realistically there will need to be shown a benefit in terms of trials, and then the drug will have to be licensed to be prescribed in people who don't have obstruction. So I think there is definite ongoing interest in this, and I would hope that there is positive data, but I think if and when this is prescribed, this will be a period of years ahead by the time that this is licensed for non-obstructive disease. Thanks. So that's the only two that I've been sent, Jayne.
That's wonderful, thank you. So I've got 8 further questions, which I'll just go through
Okay.
one by one. So there's a question about, someone says they feel very cold. They're not on blood thinning medication or beta blockers, and could the reason be due to their hypertrophic cardiomyopathy?
It's unlikely. There's not a huge amount of data to suggest that they're directly related. It's difficult to say really offhand, because as we get older, the blood supply to our peripheries, so fingers and toes, tends to get worse. And I think, as long as your blood pressure is normal and the blood supply to your peripheries is normal, I'd say it's probably not directly related to the hypertrophic cardiomyopathy. Some people do seem to be sensitive to beta blockers, which I know you've said you're not on, but many people tolerate these very well, and it is just a normal, often progression of peripheral blood vessel disease that means that people's blood supply is less good as they get older.
Thank you. And the next question, so the question is around, they haven't had a review for the last 2.5 years. Should they have reviews more often?
So it's very difficult to say without knowing specifically what your heart looks like, I'm afraid. There are people with very mild disease who've been very stable for many years, where it's not necessary to review people quite as often. And there are people at the other end of the spectrum where we know that their symptoms are progressive, or their disease is progressive, or their disease is severe, where we want to keep a much closer eye on things. So it's very difficult to answer specifically around why you've been reviewed with the frequency that you have. Generally, as I say, if things are very stable, we will see people less often than either if we've made changes to medication or we think that things are progressing. But I can't comment specifically on that without knowing your case, I'm afraid.
Thank you. So the heart is a muscle, and it says, is there any way we can make it stronger, and could that be through exercise?
Yeah, so the heart, as I say, like any other muscle, if it's working hard, will get thicker, which is something which we're really trying to avoid in HCM. So blood pressure, as I say, is the most important modifier of the thickening of the heart muscle, and it's really important that that's kept under control. Exercise tends not to affect, unless people are undertaking really quite extreme amounts of exercise, a normal amount of exercise, so running, jogging, rowing. We wouldn't expect to have a significant amount of effect on the heart muscle. So blood pressure, absolutely yes, will have an effect. We tend to encourage exercise for general fitness, to keep blood pressure down, to reduce the risk of coronary artery disease, and for general well-being and all of the other myriad effects of exercise. But generally within the sort of realms of what people would realistically do day to day, we don't see a direct correlation between amount of exercise and how the heart muscle thickens or not.
Thank you. So hypertrophic cardiomyopathy, the person is asymptomatic, they're on no medications. When they receive clinical letters after a review, they become anxious and then get palpitations. And they're finding it difficult to know whether it's the hypertrophic cardiomyopathy and a symptom of, or whether it's anxiety. They don't want to catastrophize, but also they don't want to ignore symptoms. Is there any advice you could give?
Palpitations, I've said, can be difficult because that they are a perfectly normal response to anxiety and stress and exercise, and the challenge is often distinguishing between the two. I think what we tend to do in people with HCM is that we monitor for any underlying rhythm problems routinely, and that will pick up if anything's happening in the background. It can be difficult to capture palpitations sometimes, and there are now a number of home monitors that can be quite useful. So the AliveCore device is a little Bluetooth device which people can attach to their iPhone or Android. And what it is just a little single lead ECG which people can put their thumbs on. So if you're having runs of palpitations which are very infrequent, so we may not necessarily see, we may not be recording on a monitor at the time when they happen, sometimes people can have home monitors which will give more information about what those palpitations are. My advice generally would be, if palpitations are happening at a time of anxiety, if they're not making people feel dizzy or otherwise unwell, and there's a very clear pattern to them, then they're probably benign. And it's the triggers that we were looking for previously about a quick offset, things that make people feel dizzy, or like they're about to black out, or palpitations that sort of last for more than a few minutes or longer and people feel very unwell with. But it's difficult to completely rule out, and I think if it's causing a huge amount of anxiety, then often the home monitors can be quite good just to send off to your doctor and say, actually, we're aware that you're feeling these heartbeats, that's real, but actually the rhythm that's causing you to feel this is completely normal.
Thank you, that's brilliant. So somebody said they went into A&E with chest pain, ECG and troponin were all within normal, no heart attack advised, but then they were advised that the chest pain wasn't heart related. However, their cardiomyopathy consultant says that their chest pain is heart related, and they wanted sort of advice around what they say to medics when they're seen in an A&E type scenario.
I think chest pain can be difficult because there are many things in the chest, from muscle to bone to connective tissue to lung to heart, all of which can produce different types of chest pain. And again, it's difficult to kind of comment specifically. I think there are types of chest pain that tend to be related to the heart, and that's based around what sort of things bring it on, and what the chest pain feels like. So chest pain from a heart typically tends to be something that's reproducible. Walking up hills, walking up stairs tends to be like a tightness around the chest, or a difficulty breathing. Sort of points more towards there being a heart cause of it. Things that tend not to be heart related are things that might be postural, sort of going from sitting to standing, or sharp pains, or pains that are worse on pressing. So there are things kind of in the character of the pain which make it less likely to be related to the heart. Now, again, I'm afraid it's a little difficult to say specifically whether your pain is or isn't related to the heart without knowing more about things. In terms of what to say to A&E doctors, I think just making people have an awareness of your hypertrophic cardiomyopathy, and just bringing that up as one of a number of potential things that could be causing the pain. I think it's always very circumstance specific, but I think just flagging that and making people aware that you've got that to consider as one of the number of different things which it could be.
Thank you. Can troponin be elevated in HCM without a heart attack having occurred?
Yeah, good question. So, I mean, troponin is a component of heart muscle. It can be confusing for doctors and patients alike, because it's historically, well, and commonly used as a test to look for a heart attack, basically. So when the heart muscle is injured, some of the cells break down and will release troponin into the blood, and this is what we look for. And very commonly, it is due to the fact that there's been a narrowing or a blockage in one of the arteries of the heart, which has caused an injury to the heart muscle, and that's why the troponin's been released. And it's a very good early marker that there is something going on with the heart. And in many, many cases, that is due to a narrowing or a blockage of the heart, of one of the coronary arteries. Now, that aside, there are many conditions, so hypertrophic cardiomyopathy, but also dilated cardiomyopathy and many, many other conditions which can directly or indirectly cause injury to the heart muscle. Now, many people with HCM, the heart is just in a higher state of stress, we can say, than most people's hearts. So there is a low level amount of troponin which is released because of that. So absolutely, there can be many heart muscle conditions where troponin is released, not because there's been a blockage or a narrowing of an artery, but there is just a low grade amount of stress on the heart muscle. And what we tend to see actually is many people with many forms of disease, you could check the troponin at any point in them and it tends to remain fairly constant. What we look for, I mean, particularly in people who have an acute event such as a blockage of a coronary artery, what we'll see is that it's a dramatic change in that troponin. So it will increase or decrease if it's been picked up late. And it's that change which we often look for. But in answer to your question, absolutely, the troponin is a marker of strain on the heart muscle. It's something the heart muscle can release for a number of different reasons. A heart attack being a common one of those, but certainly many people with many forms of heart muscle disease will have a mildly elevated troponin, and that's just a consequence of their condition rather than an issue necessarily with the blood vessels.
Thank you very much. Next question is that symptoms started after a stressful time in someone's life. They said they were super fit prior to this. Why weren't they aware of their sort of symptoms and condition before? Is it likely that it started around sort of their young age or around birth? And why weren't they aware of it before this stressful event?
I can't say specifically really why that stressful event was necessarily a trigger, but I can certainly talk broadly about heart conditions in the background. And HCM certainly isn't something which happens overnight. So by the time that people are aware of having, well, any symptoms at all, or by the time that we certainly diagnose people, they may have had heart disease for many years or even decades, depending on how quickly things have progressed. So this is certainly something which doesn't happen overnight. And it's only as the heart muscle becomes thicker, as we've talked about, in terms of not being able to meet the demands of the body, and causing breathlessness, or the heart muscle becoming so thick there's issues with blood supply to it, which can cause people chest pain, or sometimes people present with palpitations. That's the first point at which they become aware. Specifically why that may have been triggered by a stressful event, I'm not entirely sure, because that in itself shouldn't change the physiology of the heart. It shouldn't change the thickness of the heart muscle, or it shouldn't change how well the heart contracts or not. But there can be many other reasons related to awareness of symptoms, or sometimes blood pressure, or sort of concurrent medical problems as well, that can unmask symptoms that have been in the background for a long time. So I think the take home is certainly that things can sit in the background for a long time, and we only become apparent what is often quite late on in people's disease course, and that can be either the symptoms developing of their own course, or in your case of something triggering this for whatever reason.
Thank you. The next question is in regards to atrial fibrillation and hypertrophic cardiomyopathy. Yeah. Are there specific guidelines for atrial fibrillation in hypertrophic cardiomyopathy? Are they different for atrial fibrillation in other clinical presentations?
Super. Yeah, that's another great question. So the short answer is that the data is not prolific on this. We work based on what what is probably a consensus on atrial fibrillation. I think there's a couple of things which are really important. Is that the stiffness of the ventricle puts more stress on the atrium, which can dilate, and it puts people more at risk of atrial fibrillation. Is the first thing, which is why we tend to repeat people's Holter monitors, particularly as the heart muscle becomes more thick, to look for this actively. And the reason that we do look for it so actively is that we know the risk of forming blood clots in atrial fibrillation is greater. So there is a scoring system that puts the general population at risk of forming blood clots that determines whether we do or don't give them blood thinners. The general consensus is that actually we should be giving blood thinners much earlier in hypertrophic cardiomyopathy because the risk of forming clots is that much higher. So we tend to be more aggressive, I suppose, in thinning people's bloods to try and reduce the risk of blood clots forming. The sort of the indications to treat atrial fibrillation depend very much on people's symptoms. So there is a tendency for people where the left ventricle cavity size is smaller, or less efficient or thicker, where people do tend to have more symptoms with their atrial fibrillation. Now, AF isn't something that makes people live shorter. It's not what we say prognostically significant, in that, assuming that people don't, their blood is appropriately thinned and they don't have blood clots, people with AF tend to live as long as people who don't have AF. So any treatment for it is entirely based around symptoms, but people with HCM do tend to be more symptomatic with AF, so therefore we would potentially be more inclined to treat them earlier because they are more symptomatic. Now, the other side of that is that it can be more difficult to treat atrial fibrillation with HCM as well. So there's always a risk benefit that is a very very personal situation to the individual, but I think generally the inclination is to try and treat people earlier if that's feasible and the right thing to do.
There's a question around mavacamten. So it's around the practicalities of being considered for mavacamten treatment and the ongoing monitoring.
Yeah, so there are a couple of criteria for people potentially being started on mavacamten. At the moment, it's only licensed for people who have symptomatic obstruction. That is, people who have a gradient of what we say more than 50 millimeters of mercury, who have symptoms which we think are associated with this. As we've said, mavacamten can potentially reduce the contractility of the heart. So before starting it, people's heart has to be above a certain level of function, so for that to be considered safe. So an ejection fraction of more than 55%, which most people are. Because of how the mavacamten is metabolized, there's a couple of enzyme tests of the liver which need to be done to make sure that it's safe to give and to guide the dosing. But we would anticipate the vast majority of people with symptomatic obstructive HCM to be candidates for receiving mavacamten. People need echoes at week 4, at week 12, week 4, week 8, week 12, and then depending on what that shows, potentially thereafter. So there is one of the main issues at the moment is just the increased demand that would create for everybody who started on mavacamten who need echoes, because our echo departments are unfortunately very, very overbooked as things stand. So we're all actively trying to work out ways where we can get these potentially create slots to have people receive echoes if and when they start mavacamten. So there are a few logistical issues in terms of starting in terms of safety, but also logistical follow-up scans of echoes and things going forwards as well.
Thank you. So the person that's asked this question says they have hypertrophic cardiomyopathy with obstruction. They're allergic to all the major medications. They have an ICD implanted. They get breathless, dizzy on walking, chest pain after eating. They've had a previous septal ablation. Is mavacamten their only treatment option now?
So what we don't have data on mavacamten after septal ablation. I'm not sure what the best way forward would be. I think that's a very, very specific situation that needs a conversation with the cardiologist, I'm afraid. I can't comment on that without knowing what the reactions to previous medications are, what your gradient is, what the previous procedure was. There are options around potentially surgery if that is the safe thing to do. mavacamten may offer benefit if people's symptoms are severe, and in this may be, you know, the only remaining option, but that's very difficult to say whether that's the case with you, I'm afraid, without knowing more about it.
Thank you. So is it common to see increased trabeculations in hypertrophic cardiomyopathy?
It's a really topical question. I mean, hypertrabeculation used to be deemed its own condition. There was a very small study many years ago that showed that people with trabeculations, it was considered an independent form of heart disease. But actually what we now think is that hypertrabeculation is very much just a part and parcel of any heart muscle disease, whether that's dilated cardiomyopathy or hypertrophic cardiomyopathy. And we don't really know why, is the honest answer. We used to think that this was some kind of arrested development where the heart was in the embryo non-compacted and then progressively became more so. We think that's probably not the case anymore. We are moving away from the assertion that this is its own condition, but it may still remain to be. But certainly we see higher degrees of trabeculation, as I say, in many forms of heart muscle disease, whether that's hypertrophic or dilated or arrhythmogenic cardiomyopathy. So whether this is an association with the disease or whether it's a compensatory mechanism that the heart has in other disease states, we don't really know, but certainly we see it very often in people with various types of heart disease.
Thank you, and it is very topical, as you say. Can you get muscle pain with hypertrophic cardiomyopathy, e.g. thigh pain?
Probably not. I'd say that's very unlikely. Unless there may be medication issues, it's very unlikely to be directly related to the heart.
Okay, that's lovely. So that's the end of the questions. I don't know how many there were, but there were quite a few. So thank you everyone to for staying muted, and also for putting such interesting questions within the chat. So thank you all very much.
Thank you. They were great questions. Thank you very much.